Good afternoon, everyone. Thank you, OSWB, for the opportunity. Can I have my slides here? Yeah, yeah. So, the topic of my presentation today is be proactive and not reactive when doing cataracts and diabetics. So, I do have a conflict of interest here, and that is that my presentation is from the perspective of a retinal surgeon and may look overwhelming to others. So first question that we need to ask is, are the cataracts and diabetics different? Yes, they are. Because these patients are relatively young. They have softer cortical cataract or PSC with poor pupillary dilatation. They have other diabetic eye disease like diabetic retinopathy or glaucoma. They would have underwent multiple anti-VEGF injections or vitrectomy and have multiple systemic comorbidities. You name them and they have it. So how does being proactive mean? It means we need to be proactive before surgery, during surgery, and after surgery. So during pre-op, we need to plan ahead. We need to be very careful when we are planning this surgery. Apart from the routine cataract examination pre-op, we need to have a more holistic examination here where we do a BCVA correlation with the findings that we see. We must carefully look for NVI and NVA in the undilated state. And we must be very careful to see the periphery and not just screen the macula to know the DR status. And look for other comorbidities like glaucoma and cornea. And OCT macula is now a common investigation pre-op, but may require an FFA on OCTA sometimes. You may have to do a biometry correction based on the macular status. And please do not forget the other eye, because there are many clues that we can get when examining the other eye. Manage systemic comorbidities. Ask history, take time, know the control, the medication, understand the myths and beliefs. Take it as an opportunity to screen for other comorbidities. It develops trust. Educate them for better control, not just for surgery, but for a better healthy life. And we need a sugar below 200, but most important, do not push your patient to get it controlled very quickly, because it can lead to rapid deterioration of systemic parameters too, and of diabetic retinopathy also. And most important is to develop realistic expectations. You explain them why the cataract surgery has been done. Is it to improve vision or to facilitate your PRP? Make them understand that this surgery is not like to be their relative surgery where they have received 20/20 vision. Discuss the complications in a very subtle way and also address the need for additional treatment if required in future. Cataract surgery is pro-inflammatory. It means that it has been shown in a recent meta-analysis that after a cataract surgery, there are a substantial portion of people who can develop sight-threatening complications. And if you have a patient who are moderate or less, it is unlikely, but patients who have severe NPDR, they are likely to deteriorate, so you must stabilize them, ask for a retinal consultation, and get it stabilized before you do the cataract surgery. If you have a DME, better to do it prior to it, but if not, you can do along and a steroid or anti-VEGF injections. If you have a PDR or complicated stuff, we have the next talk for it. So what do you do in intra-op? You need to have good skills, execute well, but always have plan B and C ready with you. You have to manage pupillary dilatations. You avoid small capsular excess and avoid multifocal IL because it will make the retinal visualization difficult. Always anticipate a risk of PCR, especially if the patient had underwent multiple anti-VEGF injections or a vitrectomy, and be ready for it. Take time and clean the cortical fibers. It helps in peripheral visualization as well as reduce the risk of PCO. And always give an intracameral antibiotic because the risk of endophthalmitis is higher. Once you have done the cataract surgery, don't think the war is over. Be vigilant. Any untoward inflammation, always think of endophthalmitis because these patients have an immune compromised state. A risk of CME and DME is higher. You can give a perioperative NSAIDs, OCT and refer as required. DR reassessment is very important, as I have already said. In case of severe NPDR, they can progress faster than usual. So you might require a more closer monitoring. and the follow-up duration need to be decided case to case, not any individual one. So finally, the take-home message from my presentations are, complications are not uncommon in these situations, but excellent results are possible. Be proactive, plan ahead, execute well, and be vigilant. And finally, cataract surgery is just a chapter in the book of diabetic eye disease. So always be vigilant and make them understand that it is just a part of their journey and they need to follow up with you or your retina colleagues throughout life. Thank you for your kind attention.
Thank you. Excellent talk by Dr. Mukesh Jain. Before we go to our experts sitting on the dais, can I request, be proactive? I think Dr. Shubhankar and Dr. Arnab, they are both heading institutions like railways departments where you have to take maybe most of the major decisions in these type of cataracts. So what is your experience in diabetic cataracts one by one, please?
Yes, no doubt the incidence has gone up so much these days that in every OT you have quite a few of them. So few things we always try to do in these cases is the choice of IOLs that we use. We never would give them any multifocals or a bifocal IOL in these cases. It's just either a monofocal or even the extended depth of focus IOLs. A proper rexis is so very important. A proper centered, good rexis is what we also advise all our students as well, that these things you need to do. And definitely an OCT prior to surgery is so very important. Even if you see what you visualize the retina while doing a fundoscopy, that it's fine, but still it's preferable to get an OCT done. And as he said, inject before the surgery, or if you want to do it early, do it at the time of surgery, even if there is a little bit of macular edema. I think,
and that's it. Most importantly, you've got to spend the chair time with the patient. Dr. Home?
Another thing Arnab has pointed out, absolutely correct, but one thing is that I think regarding the central rexis, and the rexis should not be small. I think for post-op, I think for treatment of retina, I think it should be adequate enough, and the lens should cover, it should be a large, comparatively good optic. That is one point I think is clarify. And regarding, we prefer that for the compliance of the patient and other things, if needed, we in the same sitting we give intravitreal injection. If required in these cases, then call them after 1 week or 2 weeks later. It's better if needed.
Thank you. Dr. Shubhadra, please.
Thank you, Mukesh. I think that was excellent. Just a couple of points. One is that these diabetic patients are also prone to epiretinal membranes, silent epiretinal membranes. So when you do OCT, you might find a thin ERM. So these don't need treatment. And so many patients come to us, should I undergo ERM surgery? Should I not? If they're asymptomatic, there's no metamorphopsia, we don't need to tackle that. Okay, although you may pick it up on OCT, it doesn't need handling unless there's a vitreomacular traction. So of course, in those cases, you will take help of your retina colleagues. The second thing is NAION. Now, NAION is not uncommon in diabetics, and we know that cataract surgery can precipitate it. So there are certain precautions you need to take. Of course, during your initial evaluation, you will look for disc at risk, which we have, Swan Singh Harris has described as small discs without cup. These are the highest risk. Of course, normal discs can also get NAION. So what are the precautions? Avoid hypoglycemia. So take it as the first case or second case in the morning so that they are not waiting. Avoid hypotension, again, because of dehydration, summertime. That is very important. And during your surgery, there should be least fluctuation of your IOP, because a hypotension during surgery is another risk factor. Of course, if you're doing their pre-op evaluation, if you're seeing a disc at risk, get the ESR done. If ESR is high, they need treatment before you take up for cataract surgery. And those who get NAION in one eye are at very high risk of NAION in the other eye during cataract surgery or soon thereafter. So this is a group that you need to be proactive, find these patients and take the precautions. Also, vitamin D levels, it has been found, of course, in general for all thrombotic events, homocysteine. So these are some of the risk factors. Once you see a disc at risk, make sure these things are taken care of. And recently controlled diabetic, sometimes sugar is 300, 400, we control diabetes, and in 2 days we do surgery. This is a little risky because their body has still not reached that milieu where they are, the sugar has come down, but the body is not ready, so there's no hurry. You can Wait for some time and then maybe after a month or so, rather than just control it and then do cataract surgery. So these are some of the precautions, and of course there is no substitute to looking for NVI. NVI can be very subtle. If there is an NVI, so very subtle, or an NVA, and you have done cataract surgery, they will present in a week or 2 weeks with endophthalmitis-like picture, and they will look like endophthalmitis with pain and low pressure, and then the pressure will go high, and you will see a hypopion, and you will inadvertently treat them for endophthalmitis, and after 3 weeks they'll come back with full-blown neovascular glaucoma. So this entity has to be thought of. If you think preoperatively the retina looks very featureless and tessellated, get the carotid Doppler done. Look for NVI properly. You will find very subtle NVI very soon. So I of course I like to do ERG for them to pick up the ocular ischemic syndrome, but carotid artery disease is a accompaniment of many of these patients. So past history of strokes, MIs, any other vascular events, amputations. So these are the patients who would have risk of carotid artery disease also.
Thank you, ma'am. Yes, you got a question?
Presently not, but previously about 30 years back, there is a term associated with cataract surgery that was PBHI, peripheral buttonhole irectomy. Presently not, but in diabetic patients, we must be alert that peripheral iris, it is neovascularized. You should not have any trauma by an instrument or the phacoprobe. Sometimes it harasses.
Okay. So, anything else?